increase in iniquity. We live in the world that challenges increase day after day. No wonder Jesus was speaking here. In verse 16, he's
Yes, Daniel.
Would you kindly mute your...
Pardon?
Would you kindly mute your audio? Thank you. So you only unmute when you have a question to ask.
I think let's continue. We're on slide 4. I was explaining how the fibers move from the nucleus, whether they are going ipsilaterally or contralaterally. Contralateral, it means they are crossing. If the fibers from the nucleus cross over to innervate the opposite side of the person, you must know that arrangement, because when they say the right muscle is paralyzed, if you don't know exactly this movement of fibers, you'll be thinking the lesion is on the right side, and yet you have ignored that crossing over of fibers. Very, very important in making the correct diagnosis. You should know how the fibers move. For example, when the lesion involves the red nucleus, from the actual nucleus, fibers come out and pass through the red nucleus to where they are going. So if the red nucleus, which is intercepting the fibers, is involved, you have there is what we call ipsilateral third nerve palsy with contralateral loss of sensation and tremors of the arm and legs. So lesions involving the cerebropeduncle and third nerve fascicles produce Weber's syndrome. Okay. You have spastic paralysis of the contralateral arm and leg. In other words, this is the thing, because fibers have crossed, the lesion, the actual lesion, is being noticed in the opposite side from where the fibers are coming from. This is the actual drawing, nice drawing, third nerve. You can see the, where's my label? The pointer.
It does just come like that.
Okay, those they just come like that. Okay. No. Okay. Okay. Yeah. There is the nucleus, third nerve nucleus. This is the red nucleus. It means from the nucleus of the third nerve, the fibers pass through the red nucleus. Then they come to this pyramid and will come out of the brainstem. They pass in between the blood vessels and then proceed to the eyeball. What's the importance of knowing this? Because if the red nucleus is involved, there will be this spastic paralysis of the site. Then you will know this lesion is not peripheral. By being peripheral, it's not after leaving the brainstem, it's within the brainstem because of the presence of the other features. For me? Mr. Jerry? Oh, I have no idea. Could I put university? The university is the examinations officer. So after leaving the brainstem, you have now the peripheral nerve, which from the brainstem, it goes into the subarachnoid space, you know. Third nerve leaves the brainstem and passes between the posterior cerebral and the superior cerebral arteries. Travels lateral and parallel with the posterior communicating artery of the sac of Willis. Then pierces the dura just to the posterior clinoid process. Within the subarachnoid space, the nerve may be injured by aneurysm of the posterior communicating artery. Meningitis, tumors, all these are possible causes to affect the nerve fibers. Note, posterior communicating artery aneurysm typically arises at the junction of the internal carotid artery, is the most common cause of spontaneous acute complete third nerve paralysis and pupil involvement. Pupillary fibers involved is seen in 95% of cases, and the pain is always present. So if you have got what appears to be a third nerve pulse associated with pain, and the pupil is involved also, this is the site of the lesion. At the end. This is another diagram of the same, except the picture is we'll put it upside up so that you can see this is the basal part of the brainstem. This is supposed to be on the upside, the back, this is the back, this is the front part. Can we increase this? Maybe we should increase it a bit. I think so people can see. This is where the nucleus is, passes through the red nucleus, then it comes out of the brainstem. The yellow part is the brainstem. When the nerve part comes out, it passes in between these arteries. Then it continues forward through the cavernous sinus there and out there. Third nerve enters the orbit through, I've moved, okay. Once the third nerve enters the cavernous sinus, it runs dorsal to the fourth nerve and lateral to the wall of the sinus. When we say dorsal, it means it's up. The fourth nerve is down. You know, that's the meaning of dorsal. Within the sinus, once it goes through the sinus, it is susceptible to damage from carotid cavernous fistulas. What? Audio? Some more?
I want to reduce this.
Want to reduce it?
Yeah, so like the slides are.
Or to reduce the slide. Okay. This, So we're saying within the cavernous sinus, the third nerve palsy is accompanied by signs related to other ocular nerves and the trigeminal. Why other ocular? Well, the other nerves are also passing through the cavernous sinus. So one nerve affected, it will not just be that. There will be also the other nerves a bit involved. May not be involved in the same, amount. So these are within the sinus, susceptible to damage from these features: carotid cavernous fistula, aneurysm, pituitary apoplex, granulomatous process. Granulomatous, these are tumor cells which are there, if they are there. Herpes zoster at this level can also cause that. Within the cavernous sinus, the third nerve palsy is accompanied by signs related to the other ocular nerves. This is the meaning. Because within that cavernous sinus, it's not just the third nerve, there are other nerves also involved in the wall of the cavernous sinus. These are the other ocular nerves, and the trigeminal nerve is involved. Okay. Exception, third nerve infarction associated with diabetes mellitus. That's the only exception. Is a pupil sparing palsy accompanied by periorbital pain. What is the meaning of this statement? It means in diabetes you can have this pain, suggesting there is a third nerve involvement. But in this third nerve involvement, the pupil is spared. In other words, there is good pupillary function. Okay. Ischemic third nerve palsies spontaneously resolve within 12 weeks, but may recur. This is the cavernous sinus. You can see the walls of the different, you know, in the wall of the cavernous sinus. You've got these nerves: third nerve, fourth nerve, fifth nerve, and the sixth nerve. So if there is anything like this is a blood vessel, if it breaks up there, all these nerves will be affected by pressure. What is this? Chiasma. Chiasma is the yellow one. That's the nerve. This is the pituitary, and this is the pituitary stalk coming up like that. Okay. Peripheral nerve, orbital space. Third nerve enters the orbit through the superior orbital fissure, then divides into superior and inferior branches. Immediately it enters through the superior orbital fissure into the orbit now. What is in the orbit? Centrally, you've got the optic nerve, which goes into the eyeball there, anteriorly. Then you've got muscles, superior rectus, inferior rectus, lateral rectus, medial rectus, and the obliques that help in the control of eye movements. So third nerve enters the orbit through the superior orbital fissure, then divides into the superior and inferior branches. The superior branch carries fibers innervating the superior rectus and the palpebral superioris muscle. Inferior branch carries fibers innervating the medial rectus, inferior oblique, and inferior rectus, the muscles. This branch also carries fibers to the ciliary ganglion, which eventually innervate the iris, sphincter, and ciliary muscles. Note, most common cause of intraorbital involvement of third nerve is trauma, neoplastic involvement, the tumors within there, and the virus. I think trauma is more involved, but there are these other causes. When you say neoplastic, it means there is tumor cells may not just affect the, you are going to have a situation, may not just be affecting the nerve, other features, because there is now compression if a lot of tumor is there. There will be other features suggestive of compression. No? Where are we? Going up? Special syndromes of oculomotor nerve. Aberrant regeneration of the third nerve occurs during repair phase following injury to third nerve from trauma. So if someone has got trauma, you treat it as trauma. But you will notice later on, the movement of the eyeballs are not consistent with what we're talking about here. That's the aberrant regeneration. Instead of looking medially, you find the eyeball is also trying to look up. It means fiber, the patient must have had trauma, which injured the nerves, but in regenerating, they go and innervate another muscle. That's the meaning of aberrant regeneration, not the normal regeneration to innervate the correct muscle. So trauma, aneurysm, tumors, these are the causes of aberrant regeneration. Okay? Sprouting axons are misdirected so that they re-innervate the wrong extraocular muscle. Not clear?
Struggling.
So the sprouting, the nerve fibers which are growing out, they are misdirected. So they end up innervating the wrong extraocular muscle. Look to the left. The patient, you expect the if I say look to the left, this is my left, isn't it? The muscles will act lateral rectus is the one which is eyeball. Right. But it's the right rectus. They as a pair. Okay? For left, both eyes are supposed to look there. There's nothing like one is still looking in front. So this is the pair. That's the understanding. So to the right. In the right side, it's the right rectus. In the left eye, it will be the medial rectus. Those are the paired muscles. If we're here, several different patterns of movement may result, depending on which nerve fibers are injured. Okay. The third nerve misdirection never occurs with diabetic third nerve neuropathy. In other words, look this side. You expect the patient to be looking this side because the left lateral rectus is working and the right medial rectus is relieved a bit. If by looking this side, the patient is just looking up again, it means there's misdirection here. That cannot be, this misdirection of improper movement is not due to diabetes. So don't say diabetes. You should say diabetes is the best way to fail. Diabetes does not cause, in other words, aberrant regeneration on follow-up. It is never, diabetes is not a cause. Okay? Chronic third nerve poses, regardless of pupil involvement, they need neuroradiologic investigation for a mass lesion along the course of the peripheral. When they say mass lesion, we're talking of a tumor. You know? The next nerve is the trochlea, fourth nerve. What does the trochlea do? No idea. The nucleus, first of all, is located in the periaqueductal gray matter beneath the aqueduct of Sylvius. Caudal means backward, slightly backward to the third nerve, to the nucleus of the third nerve. Caudal to and continuously with the third nerve. You have a third nerve in front, but caudal behind. That's the meaning of caudal. So fasciculus, the fibers from there, axons of the fourth nerve, pass round the aqueduct, decussating, crossing over. These fibers, like that. This is the level. Okay? Mm-hmm. So if you've got fiber, this is the nucleus there, say nucleus there. This will curve around the aqueduct, decussating completely and leaving the brain like that. What does that mean? It means if the lesion is here, if the lesion is there, it's the opposite side which is involved because of this crossing over. By decussating means the fibers are crossing over, bypassing the aqueduct. This is where the cerebrospinal fluid passes. This. So axons from the fourth nerve, they curve round the aqueduct, decussating completely and leaving the brainstem on the dorsal surface at the level of the inferior colliculus. Okay. It's important to appreciate this arrangement of the anatomy so that the peripheral nerve will show, like, for example, if the lesion is on the left side, the peripheral nerve which will come out because of this crossing over, it will be on the opposite side. But unless you understand the way the fibers move, you will not make that mistake that, okay, suppose this is nuclear. What is which type of nucleus is involved? The fact is that it's on the right side doesn't mean it's nuclear on the right, because it means you didn't understand this crossing over issue. If you understand the crossing over issues of the fibers, then you know that although the lesion is showing there, it must be on the other side at this level. So these are the fibers. From there they cross. From there they cross. It's crossing over. So if the lesion is nuclear, here it's the opposite side which is going to be affected. For this nerve to be affected, it's the other side to be affected. So this concept must be very, very clear. You could have a good idea. No, it's the fourth nerve. Yes. From this, at what level? That's what the examiner is interested in. We don't want too many. We want answers. Okay. Peripheral fibers, these are the ones now coming out. Okay. Trochlear nerve curves around the brainstem to pass between the posterior cerebral and the superior cerebral arteries. I think this was shown more clearly here. These dark structures, these are the blood vessels. Those are the arteries. So it passes in between. What it means is that suppose there is a lesion of these arteries attacking, compressing the nerve here. The lesion will be on the same side. Understand? But where is this same side of the lesion? Well, it's on the same side, but it originates from the other side. The nucleus is on the other side because there is this crossover before coming here. That's what people must understand. Okay. Let's go now to that one. Trochlear nerve curves forward around the brainstem to pass between the posterior cerebral and the superior cerebellar arteries. Then pierces the dura mater behind the cavernous sinus below the third nerve. Enters the orbit through the superior orbital fissure. Once it's in the orbit, it goes there to innervate the superior oblique muscles. So the superior oblique muscle in the right orbit is innervated by fibers coming from the right, from the left side. isn't it? Because you saw at the from the nucleus there's crossing over. Eventually, once they cross over, this one originating from that nucleus, which is on the right side, ends up in the left side. The one which originated from the left side ends up in the right side. Very important to appreciate. When you locate the lesion, they will always ask you, which one is this? Is this the left or the right? Don't be carried away because the features are showing here. At this level, it must be this level. So, the fourth nerve is the longest of the cranial nerves and the only one to exit on the dorsal surface of the brainstem. The others, they exit on the ventral side, not on the back side. Okay. Because of its long course within the subarachnoid space, peripheral trochlear nerve is subject to damage from closed head injury due to contra-cool forces. What is contra-cool forces? Contra-cool forces, you have a force here, the brain shakes back, forward and backward like that. Those are the contra-cool forces. Because there is a long passage here, the nerves are likely to be injured with that movement. Large amplitudes of vertical fusion are usually present in congenital, but not in acquired fourth nerve. Okay. Is the last? No, that's still going easy. That's the last one. No, huh? 3 more.
15.
15 more.
14
Just,
more.
huh?
14 more.
Oh, let's not talk about it. Let's just continue. So, this is the fourth nerve. I want to see what is the course of the fourth nerve. When you look at this is the dorsal part. It comes from there, crosses over there, and it comes to enter the subarachnoid space there. That's the special syndromes of trochlear nerves. Brown's syndrome. It's a syndrome of the trochlear tendon sheath characterized by restricted movement of the superior oblique tendon at the level of the trochlea. This is not the nerve involved, it's the sheath around. Okay, the coverings around is called the sheath. Restricted movement of the superior oblique is what happens now. Syndrome may occur on either a congenital or acquired basis. It can be congenital or can be acquired. Superior oblique myokemia, where there is a failure to function properly. Syndrome caused by unilateral episodic twitching of the superior oblique muscle on one side.
You have to be quite fast taking the meeting or cutting 10 minutes back.
There are 15 minutes. Don't worry. We can continue even tomorrow. What is important is people must understand. It's not just about running away at the meeting or cut. Someone has to pay. Today I can up. If you get a small portion, what will better work? It's better. I always believe it's better I spend more time explaining to the students than rush through them. They've heard nothing. It's better we go slowly, even if it means 2 days. Me, I don't mind. So that the students can go and read, come and ask questions to me, and understand the function, how these things are moving. So rushing, there will be no rushing. Someone?
Listen.
They're listening. Okay. Special syndromes of the trochlear nerve. There's Brown's syndrome, syndrome of trochlear tendon sheath, where you have restricted movement of the superior oblique and also the superior oblique tendon at the level of the trochlea. The syndrome may occur on either congenital, it can be congenital or acquired. Okay. Superior oblique myokemia syndrome caused by unilateral episodic twitching of the superior oblique. Oh, good job. The superior oblique myokemia caused by unilateral episodic twitching of the superior oblique muscle. Lack of contraction, proper contraction. So instead of lack of that, you find the muscle is just twitching. That's what is called the superior oblique myokemia.
So how long does it last?
It depends. What is the cause? Depends. Causes can be different. This one is what isolated the fourth nerve pulse clinical evaluation. You use what is called the Parks-Biushowski three-step test to test the fourth nerve clinical evaluation. You use this method, Parks-Biushowski three-step. In other words, there are three steps. Step one, identify the side of hyperdeviation in primary position. They are looking at the patient is looking at you. Which eye is higher than the other one? Okay. Identify the side of hyperdeviation in primary position. You better not you now women in so you sit with the patient looking at each other. Look at me, sir, or madam, look at me. You can see that one eye is looking higher than the other one, you know? It means this one slightly elevated. This is the side of hyperdeviation. You record. Next, this reduces to 4 the number of vertically acting muscles in 2 eyes. Right hyperdeviation, possible weak muscles is the right inferior rectus, right superior oblique, left inferior oblique, and left superior rectus. Okay? In right hyperdeviation. In left hyperdeviation, is the left superior oblique, left inferior rectus, right superior oblique, and the right inferior oblique. These are the weaker muscles. In other words, you are now reducing. You are trying to zero in which muscle ultimately. By just observing which eye is higher than the other, you are now, we've got these groups of muscles. Okay. Next. We go there. Observe the increase in hyperdeviation with lateral gaze to the opposite side. In other words, apato achira chita determining which one is, worse, isn't it? Hyperdeviation. So there are 2 groups of muscles. You categorize either this group or that group, whether it's left or right. Now, if you think this is the eye affected is the left side, when the patient looks to the opposite side, it's in the left eye, the patient looks to the right side, there is more hyperdeviation. Observe an increase in hyperdeviation with the lateral gaze to the opposite side. This is the left side, opposite side in the right. Look to the right. If you have chosen that the region is in the left side, ask the patient now, they are looking straight, look to the right side, not turning the head, just the eyes. Then you will see that if the lesion is here, there is now again, the eyeball is going higher up. There's hyperdeviation, increase in hyperdeviation. Vertical, like that. Are we clear on that aspect? You need to have a patient whom you will go through with this process. Once you have gone through, you've got correct diagnosis, you will see that it's manure. It's easy, yeah. You just follow these steps. Step 2. This is a chart which actually should be in the clinic, written and laminated. Is it an oblique muscle? Chart it. Use it to make a diagnosis. Students can make a diagnosis easily. What's that increase? No problem. So step 2 is to observe an increase in hyperdeviation with lateral gaze. Lateral gaze. If this is lateral gaze, the medial gaze. The medial is the center. Hyperdeviation initially in the right side, lateral gaze will be there. The left side, lateral gaze will be there. So if this appeared higher when you observe directly, you think the lesion is here. If you ask the patient, can you now look there? You're not turning the head. I'm not saying turn the head. You just say, look to there while we are looking forward. Can you look to this object on this? You find if the eye goes a bit higher again, increase in hyperdeviation, it means the lesion is here. Vertical rectus muscle and whatever. So when you notice step 2, if there is an increase in hyperdeviation with lateral gaze to the opposite side of the suspected muscle, oblique palsy narrows possible weak muscles to that. In the right eye, these will be the possible weak muscles. In the left eye, these will be the possible weak muscles. That's the whole idea of this chart. Then note, vertical rectus muscles, the speedorectus and inferior rectus, they just lift or drop the eye down. These have their greatest vertical action and least torsional action when the eye is abducted. What is abducted? Looking inward, not outward. So if the patient is there, ask them to look inward. You find that's when the lesion is affected more. Okay. In left hyperdeviation due to paralysis of the left inferior rectus, this will be worse on gaze to the left, since the left eye is abducted on gaze to the left.